Welcome to American Medicine YouTube channel. We bring in the most up-to-date information on different topics to the medical community. In this particular one, we bring in Guillain-Barré Syndrome. It is based on, most of the talk is based on diagnosis and treatment guidelines came out in 2023 by European Academy of Neurology and Peripheral Nerve Society. Guillain-Barré syndrome is a rare but potentially life-threatening immune-mediated polyradiculoneuropathy. It causes acute flaccid paralysis. It's a typical post-infectious disorder triggered by bacterial or viral infections, most commonly by Campylobacter jejuni or Zika virus. It typically presents with paresthesia, pain, or weakness of the limbs that rapidly progresses in days. Around 20% of the patient may develop weakness in all four limbs, leading to respiratory failure requiring mechanical ventilation. The most common cause, acute flaccid paralysis worldwide. The global incidence is 1 to 2 per 100,000 persons per year. In most lower and middle income countries, including African and Asian continent, no epidemiological data are available. So the global incidence may be different, most likely higher. The males are affected more than females 1.5 times. The risk of GBS steadily increases by 20% for every 10-year increase in age. The more you age, the more susceptibility to get the GBS. The incidence of GBS fluctuates seasonally, probably related to infections that can trigger the disease. This map shows the incidence of various countries and continents across the globe. As you can see, vast majority of African countries and Asian countries have not reported the incidence. Hence, the incidence may be lower than what is being projected at this point. The mortality of GBS is 2% to 10%. In Europe and North America, the mortality is 2 to 7%. In countries like Bangladesh, it is 14 to 17%, and Egypt, 16%. Disparities are because of limited availability of treatment or specialized care in low-income countries. For example, in Bangladesh, only 10 to 12% of the patient can afford either IVIG or plasma exchange. So what are the risk factors for mortality? Higher age, severe weakness at an early stage of the disease, and need for mechanical ventilation. GBS always associated with preceding event. That could be Campylobacter jejuni, Mycoplasma, cytomegalovirus, Epstein-Barr virus, hepatitis E virus, or Zika virus. Campylobacter jejuni is the most common preceding infection worldwide. 30% of the cases one can isolate Campylobacter jejuni. The second most frequent infection is Mycoplasma. The other infections like dengue, chikungunya, varicella zoster, and HIV can also be a preceding event. Vaccinations have been implicated, malignancy, trauma, and surgery involving bones and digestive organs have been implicated as the preceding event for GBS to develop. I have to say one thing about vaccinations. Even though there are lots of literature accusing vaccination as a preceding event, the further research did not show there is an increased incidence of GBS among those patients who received vaccination prior. There are lots of outbreaks of infectious disease associated with increased incidence of GBS. For example, epidemic of Campylobacter jejuni in China 2007, Mexico in 2011, Peru 2018 to 2023, and Zika virus epidemic that happened in South America between 15 and 16, and most recently, the COVID-2 virus epidemics have been linked to the recent increase in GBS across the globe. Pathophysiology. GBS is usually a monophasic condition in which the immune system aberrantly disrupts the function and structure of the peripheral nervous system. The exact pathophysiology is uncertain, but there are two areas have been debated. One is autoinflammatory, which is driven by innate immune mechanisms, or autoimmune, driven by adaptive immunity. But the GBS does not have a typical features of autoimmune disease, like because of male preponderance, short duration, and self-resolving monophasic course, lack of association with specific human leukocyte antigen. Particular slide shows schema of how the nerve damage happens. As you can see, the trigger in this particular picture, Campylobacter jejuni, triggers toll-like receptors in T cell and B cell. It causes antibody production, then affects the nerve sheaths. The way it happens is the antibiotic sits on the surface of peripheral nerves and activate complement and form membrane attack complex that affects the myelin sheaths as well as axons. During this time, it produces specific antibodies. One is GM1 and GD1 antibodies. They are particularly seen in vast majority, the most common motor sensory GBS. There is a specific CQ1A antibody is produced in the variant, the most commonly known as Miller-Fisher syndrome, that causes ophthalmoparesis and ataxia. There are other groups like Neurofission 186, 155, Casper1, and Contactin 1. These antibodies have been isolated in patients with acute inflammatory or chronic inflammatory polyradicular neuropathies. So even though the antibodies are not used in the diagnosis, but in subset of patients, knowing the antibody further strengthens the diagnosis of Miller-Fisher syndrome and other polyradicular neuropathies. Regardless of the primary mechanism, the final outcome in GBS is peripheral nerve damage that includes endoperineural and subperineural edema, inflammatory infiltrates, segmental demyelination, and axonal damage. This slide depicts the disease course of GBS. There is always a preceding infection or event, followed by the immunoglobulin surge or antibody surge that affects gangliosides and causes disease manifestation. The progression of the disease happens anywhere between few days but does not exceed more than 4 weeks. Then the plateau phase ensues. It can be 2 to 6 months to all the way up to 2 years. Then the recovery phase and final disability. Most of GBS patients will not have major residual deficit. They may leave a small or minor residual deficit in most of the patients. Clinical hallmark of typical motor sensory and motor forms of GBS is a progressive flaccid limb paralysis and areflexia. Sensory loss is present in predominant motor sensory form but absent in the motor form. During this progression, one should watch for respiratory failure and autonomic dysfunction. It often manifests as fluctuation in blood pressure. The hallmark of MFS, that is Miller-Fisher variant, the most recognizable variant of GBS, triad of ophthalmoplegia, ataxia, and areflexia. These are the different patterns of the disease. As you mentioned earlier, motor sensory is the most common. Sensory being milder, motor will become very prominent in this particular variant. Another variant, you will see purely a motor flaccid paralysis without any sensory involvement. The third, we call it as regional variant. It's confined to the lower limbs. It presents as paraparesis. Sometimes it can evolve into tetraparesis involving lower limbs and upper limbs. Another regional variant is called pharyngeal, cervical, and brachial, where you have a neck muscles and the shoulder muscles and upper limb muscles are involved. It can present as bilateral facial palsy with paresthesias. When you have a bilateral facial palsy, one should entertain the possibility of it could be GBS. Sometimes it presents as a pure sensory form, but it affects less than 1% of the patients, very rare. The next is Miller-Fisher syndrome, the most recognizable GBS variant, wherein you will have ophthalmoplegia, ataxia, and areflexia. Another variant of Miller-Fisher syndrome is called Bickerstaff brainstem encephalitis. This is the only GBS variants have altered mental status. None others have altered mental status. But in this particular one, the MRI will show the white matter changes, and also the serology will show the CQ1A antibody. This is another grouping of different patterns. The motor sensory is the most common. It has a motor manifestation and sensory manifestation, but there is no CNS manifestation like altered mental status. Motor, acute flaccid paralysis with no sensory involvement at all. It comprises 25%, most commonly seen in Asian continent. Paraparetic, as you mentioned earlier, it involves only lower limbs. There is no cranial neuropathy involvement or central nervous system involvement. Next group is called regional variants. Pharyngeal, cervical, brachial, where the proximal upper limbs are involved. Bulbar can be involved, but there is no altered sensation. There is no CNS involvement. They have a specific GT1A antibodies present in that particular variant. Bilateral facial palsy with paresthesia again accounts for less than 5%. Distal limbs affected and the bilateral facial muscles are involved. And its pure sensory form, it affects only less than 1%. There is no motor involvement, only sensory is involved. It has a specific antibody presence, which is GD1B. The next group is Miller-Fisher syndrome and Bickerstaff brainstem encephalitis. That accounts for anywhere between 4 to 25% or less than 5%. They can have an overlap with motor sensory and motor GBS. They will have ocular manifestations and they have a specific antibody present, GQ1B and GT1A antibodies. The Miller-Fisher syndrome can be associated with motor sensory and motor, that is called overlap. Miller-Fisher syndrome can be isolated, the typical one, autonomoplegia, ataxia, and areflexia. Sometimes it can be incomplete. The motor sensory form is the most frequent in Europe and North America. The motor GBS without any sensory symptoms, more frequent in some countries in Asia like Bangladesh. GBS variants. It predominantly involves one part of the body called regional variants. It can be pharyngeal, cervical, brachial, or it can be bilateral facial weakness with limb paresthesia. Sometimes it may be paraparetic. It may evolve into tetraparesis. The typical Miller-Fisher syndrome, otherwise called MFS, have ophthalmoplegia, ataxia, and areflexia. Fairly large proportion of MFS have other motor sensory elements. We call it as GBS MFS overlap syndrome. It can be incomplete without all three typical clinical features. The third variant is Bickerstaff brainstem encephalitis, BBE. It's a rare wherein you will have ophthalmoplegia, ataxia, and pyramidal tract signs and impaired consciousness. When you do an MRI scan, one can see white matter changes. This is another condition one should remember because it can be easily confused with GBS, especially when it presents acutely. 5% of the patients initially diagnosed with GBS later turn out to have acute onset chronic inflammatory demyelinating polyradiculoneuropathy, CIDP. Few of these patients do not respond to IVIG or plasma exchange. They have a specific antibodies against nodal and paranodal antigens like NF155, Casper1, and CNTN1. So these patients may confuse, but treat like GBS initially, then you can change your diagnosis later on. There are three pathogenic subtypes have been described in GBS, namely acute inflammatory demyelinating polyradiculoneuropathy, AADP, acute motor axonal neuropathy called AMN, acute motor and sensory axonal neuropathy, AMSCAN. Does not really matter which pathogenic subtypes the patient belongs to, the treatment is going to be the same based on GBS disability score. Outcome measures. This is the most important slide of this one because the GBS disability score is used to manage the patients. When the GBS DS score is 0, that means the patient is healthy. When they have minor symptoms and capable of running, that is called GBS DS1. GBS DS2, able to walk 10 meters or more without assistance but unable to run. GBS DS3, able to walk 10 meters across an open space with help. GBS DS4, bedridden or chair-bound. GBS DS5, requiring assisted ventilation for at least part of the day. And GBS DS6 is the patient is dead. It was validated and published in Lancet Neurology in 2007. It has been widely used. There are other disability scores used. Please stick to GBS DS scores because they are widely used and the therapeutic regimen based on the GBS DS scores. Now, how to diagnose? It is based on the guidelines published in 2023. Required features: progressive weakness of arms and legs, absent or decreased tendon reflexes in affected limbs, and progressive worsening in less than 4 weeks. GBS does not worsen beyond 4 weeks as per the current understanding. The supportive features of GBS is relative symmetry, relatively mild or absent sensory symptoms, having cranial nerve involvement, especially bilateral facial palsy, autonomic dysfunction, respiratory insufficiency, pain, and recent history of infections less than 6 weeks ago. Supportive lab tests: cerebrospinal fluid, increased protein and white cell count less than 5. The serology, especially in Miller-Fisher syndrome, identifying GQ1B antibodies may be helpful or increase the chances of making the diagnosis. Electrodiagnostically, nerve conduction studies will show the evidence of peripheral neuropathy. But in the early stages, it can be normal, so it needs to be repeated. The finding inconsistent with GBS are as follows. When there is an asymmetry, think of something else than GBS. Severe respiratory infections happens faster, especially in the first 24 hours. Most likely, different diagnosis than GBS. Predominant sensory signs. Fever at onset. Sensory level or extensor plantar response. Hyperreflexia. Even though initially the GBS can have hyperreflexia, as persistent hyperreflexia makes GBS unlikely. Having bladder and bowel dysfunction, abdominal pain or vomiting, nystagmus, alteration of consciousness. The only exception is Bickerstaff brainstem encephalitis, abnormal routine blood test, and CSF cell count more than 50, it pretty much excludes the possibility of GBS. So what are the differential diagnoses? What are the various diseases that can mimic like Guillain-Barré syndrome? The brain, encephalitis, it's easy to distinguish. These patients present with drowsiness and seizures and spinal tap will show pleocytosis. Brainstem stroke, hyperacute sudden onset distinguishes from GBS. Transverse myelitis, sensory level, brisk reflexes, and MRI will show the hyperintense lesion. Malignant infiltration, again CSF pleocytosis, and they will have cauda equina syndrome. The infection of the anterior horn cells by different enteroviruses present as fever and CSF pleocytosis, and the normal nerve conduction studies. Microbiology will show the virus. Neurologic amyotrophy, asymmetry, pain, findings limited to the nerves affected, distinguishes from GBS. And CME HIV radiculitis, subacute presentation, again identifying HIV CMV serology, CSF pleocytosis distinguishes. Among peripheral nerves, let me kind of talk about this one later. Porphyria, family history, and raised urinary porphobilinogen, Lyme disease, history, characteristic rash, and serology distinguishes from GBS. Thiamine deficiency, again, it is associated with hyperemesis gravidorum and nutritional deficiency. And they will have abnormal thiamine levels and erythrocyte transcrystallase activity. Diphtheria, again, laryngeal infection, isolation of Corynebacterium, diphtheria distinguishes. Critical illness, the history distinguishes from GBS. Metabolic and electrolyte imbalances, again, the electrolyte abnormality distinguishes from GBS. The one thing I left was CIDP. In acute presentation, it mimics exactly like GBS. They will have albumin cytological dissociation. Nerve conduction will show demyelinating neuropathy, and the neuroimaging may show widespread enlarged nerve roots. That may be very distinguishing, but it's not that much. So these patients need to be treated like GBS when there is a less response or persistence of symptoms, put us back into chronic inflammatory demyelinating polyradiculoneuropathy. Neuromuscular junction, it's easy to distinguish, but one has to keep in mind myasthenia gravis, fatigable weakness, relapsing and remitting, botulism, rapid progression, pupillary abnormalities, dysautonomia, and descending paralysis. In GBS, we will have ascending paralysis. Lambert-Eaton syndrome, proximal weakness, depressed tendon reflexes, and autonomic changes. Muscles diseases like inflammatory myositis and critical illness myopathy, they all will have increased creatine kinase level. And nerve conduction studies will be normal, EMG will be abnormal. Now, how to treat? Before we treat, how to predict the need for ICU admission. GBS can present with rapidly progressive weakness leading to respiratory insufficiency in hours to days. Typically, it does not happen in the first 24 hours, but it can progress to the level we need a support, respiratory support, the next day or two. So elective transfer to ICU may result in early recognition of the need for ventilatory support and intubation. Assessing the risk of respiratory failure early in course of GBS, very important. The way we can use is modified EGRIST or Erasmus GBS Respiratory Insufficiency Score. What does that entails? It requires 4 clinical factors: rapid disease progression, bulbar palsy, weaker neck flexion, and bilateral hip flexion. The 4 elements needs to be evaluated and identify those patients so that they can be monitored much better in ICU than on the floor. Once you admit in ICU, regularly assessing the risk factors is very important, especially those patients who have GBS-DS grade 4 and above. That means unable to walk 10 meters even with aid. They are bedridden. Neck flexion, facial and bulbar weakness, especially inability to cough, need to be assessed. Autonomic instability such as fluctuations in blood pressure and heart rate. Regular assessment of forced vital capacity, single breath count. When available, maximum inspiratory pressure or maximum expiratory pressure needs to be measured and monitored periodically. When you have elevated liver function test, infection with herpes simplex and CMV or electrodiagnostic features of demyelination, they are highly likely to have respiratory or likely to need respiratory support than otherwise. So when you have elevated liver functions and HSV, CMV positive, it is preferable to watch in ICU than in the floor. Forced vital capacity should be checked 3 to 6 times a day, and most of the centers use every 4 hours. When there is forced vital capacity fall more than 30% of the predicted baseline should alert concern. If it is more than 30% fall in 24 hours, needs transfer to ICU. More than 50% decline from the predicted baseline, need for ventilation. The elective ventilations can be done when the forced vital capacity is less than 20 ml per kilo, and mechanical ventilation is inevitable when the vital capacity is less than 10 ml per kilo. The maximum expiratory pressure is less than 30, maximum inspiratory pressure less than 40 indicates the need for elective ventilations that needs to be considered imminently. After discharge from ICU, the frequent monitoring of potential late respiratory and cardiovascular complications. So even after discharging from ICU, one needs to monitor for the autonomic dysfunctions and respiratory insufficiency. How do you treat? There are 4 elements discussed in these guidelines: plasma exchange, intravenous immunoglobulin, corticosteroids, and other treatments. The most important thing that works are plasma exchange, intravenous immunoglobulin. Plasma exchange. Plasma exchange should be started as soon as possible in GBS patients, especially when the GBS-DS score 3 or more and within 4 weeks from onset. Current recommendations are 5 exchanges over 1 to 2 weeks with a total exchange volume of 12 to 15 liters in patients who are severely disabled. 2 exchanges in GBS patients still able to walk unaided. That means GBS-DS grade 2, within 2 weeks you have to give 2 exchanges. GBS-DS grade 3 and above, 5 exchanges over 1 to 2 weeks. Even in those patients who are still ambulatory but have fast rate of deterioration, risk of requiring ventilatory support, swallowing difficulties, those patients also need to be treated with a plasma exchange, 4 to 5 exchanges over 1 to 2 weeks, similar to GBS-DS 3 and above. These are the 2 groups. They do not need plasma exchange when the GBS-DS grade 1 and GBS-DS grade 1 or 2 at weeks, but they are stable. Those patients you do not need plasma exchange. Everyone else needs to be plasma exchanged. Next one is IV immunoglobulin. IV immunoglobulin is as efficacious as plasma exchange. The indications are very similar to plasma exchange. The GBS-DS grade 3 or more needs to be treated 5 days in the first 2 weeks. The guidelines recommend the standard course of the treatment, which is 0.4 gram per kilogram per day for 5 days. There are other regimens available: 0.4 gram per kilo per day for 3 days, 0.4 gram per kilogram per day for 6 days, 2-day regimen of 1 gram per kilogram per day. The 2023 guidelines recommend stick to the standard course rather than other alternatives. There are few things very similar to plasma exchange. Even when the patient is GBS grade 2 within 4 weeks of onset, who has faster rate of deterioration, risk of requiring ventilatory support, swallowing difficulties, also needs to be treated with 5-day course of immunoglobulin. Treat GBS patients unable to walk unaided 2 to 4 weeks from onset with either plasma exchange or IVIG. Consider IVIG in GBS-DS grade 2 within 2 weeks with stable but still deteriorating. In particular, and there are also other features of GBS. Those patients also need IVIG. So the indication for IVIG is very similar to plasma exchange. GBS-DS score 3 and above, 5 days course. GBS-DS 2 with the risk of fast rate of deterioration, risk of requiring ventilator support, again treat with 5-day course of IVIG. IVIG is not advised in GBS-DS grade 1, that means milder form of GBS, and GBS-DS grade 1 or 2 with stable, presenting 2 to 4 weeks from the onset of weakness. Is there an indication to give IVIG after plasma exchange or to do plasma exchange after IVIG? These 2023 guidelines do not support IVIG following plasma exchange or plasma exchange after IVIG. Current guidelines strongly recommends against the use of corticosteroids. And also it recommends against using IV methylprednisolone. Even though they are inexpensive, there is no trial evidence to support the use of corticosteroids in patients with GBS. In fact, the intermediate high dose of oral corticosteroid may even harm the GBS patients. Immunoadsorption and immunoadsorption followed by IVIG. The current guidelines does not support immunoadsorption. It's a technique to remove the possible pathogenic antibodies. So these guidelines do not recommend immunoadsorption alone or immunoadsorption followed by IVIG. Other pharmacologic treatments like eculizumab, it's a complement blocking agent. As we know, complement is important in forming the membrane attack complex, as we explained earlier. These guidelines recommend against using eculizumab because we do not have available evidence to support the use of eculizumab. And also these guidelines recommend against using other monoclonal antibodies like alemtuzumab, brain-derived neurotrophic factors, CSF filtration, cyclophosphamide, interferon beta-1a, muromab, CD3, mycophenolate, tripterygium. So none of them are. So only two you need to remember is plasma exchange and IVIG. And the guidelines do not recommend neuromuscular electrical stimulation within 2 weeks after the onset of GBS. And again, it recommends against using 3,4-diaminopiridine to improve the muscle strength. So this slide shows and when to use plasma exchange and IVIG. As we discussed earlier, GBS-DS scores more than 3. If you have a plasma exchange machine, use 4 to 5 exchanges in 1 to 2 weeks. If you don't, use IVIG over 5 days. In children, we prefer IVIG. Number one, IVIG is available in all the centers, easy to use. You do not need a machine to run, and we do not need a vascular access. As a result, IVIG is the preferred form of treatment. You can start early and you have to give for 5 days rather than 4 to 5 exchanges for 1 to 2 weeks. The GBS-DS2, as we explained earlier, with deterioration and you expect they may need a ventilatory support, those patients can be preemptively treated with two exchanges in 1 week or 5-day course of IVIG. Those who have a GBS DS1, GBS DS2 stable, non-progressing, those patients do not need either plasma exchange or IVIG. During the follow-up, when there is a treatment-related fluctuation that is defined as initial clinical recovery and stabilization of treatment, then the secondary deterioration. These patients need to be treated again when those patients already received plasma exchange, given another course of plasma exchange. Those who received IVIG need another course of IVIG. There are certain clinical predictors to assess for respiratory failure and also inability to walk independently. Even though we discussed earlier, this is 4 parameters you need to assess, like rate of progression, bulbar weakness, weakness of neck flexion, and hip flexion. Inability to walk independently, we either use egos or modified egos. Age is an important factor, preceding diarrhea, and GBS disability score. My recommendation is confined to the one scoring system, which is DBS or DS or GBS disability score, because it is being followed across the nation and well studied. Most patients with GBS need to be treated with physiotherapy, speech, swallowing, and occupation therapy. Identification and starting the therapy when the patient is already in the hospital is the most important determinant of continuation of therapy after being discharged. These patients have lots of psycho-emotional issues. They need to be diagnosed and treated accordingly. As you can see, these patients can have depression, anxiety, stress, reactive psychosis, sleep disturbances, fatigue, that's more common, changes in daily activities, changes in work, sexual problems. They need to be identified and treated accordingly with appropriate personnel. Treatment of pain. The pain is an important component even initially and during the recovery. These guidelines recommend tricyclic antidepressants, pregabalin, gabapentin, or serotonin noradrenaline reuptake inhibitors such as duloxetine or venlafaxine as a first-line treatment, even before tegretol or carbamazepine. So these patients benefit from giving any of those medications. We prefer gabapentin. So what is the role of yoga, meditation in improving emotional well-being? These current guidelines do not make any recommendation for or against using yoga or other meditational activities to improve the emotional well-being. Treatment of fatigue. Fatigue is more common, as you can see, 38 to 86%. Either you can use pharmacological or non-pharmacological strategies, like a graded exercise program, cognitive behavioral therapy, and physical fatigue management strategies can be used. This recommendation does not advise for or against exercise training for fatigue, but it's very unlikely that exercise would be harmful, so we recommend the graded exercise program. Definitely not only improve the muscle strength, and also it improve the emotional well-being of the patient. So now, what are the risk factors for poor outcome, meaning inability to walk unaided after 3 to 6 months? Older age, preceding diarrhea or gastroenteritis, higher GBS disability scores at admission, lower MRC sum scores at admission, decreased CMAP, that is compound muscle action potential amplitude. This concludes the seminar on Guillain-Barré Syndrome based on 2023 guidelines. Please like our channel and share if you like it to other medical providers, medical students, postgraduate students, and other trainees. Thank you for watching.